Please join me in welcoming Laura.
Thank you very much for having me. I can't tell you how honored I am to be here with such a distinguished audience, and I'm excited to go maybe a little deeper than I was able to in some of my reporting, just because I know that you're a very knowledgeable audience. So today I'll cover why I have an interest and why a lot of Canadian reporters have an interest in maternal, newborn, and child health, what I looked at in the Travers Fellowship, what I learned, and what comes next, because I know everyone's very interested in the change in government and how that could affect the program. Oh, that's a photo of a hospital in Zanzibar. So why maternal health in Canada? Why did Canada go with this? I'm going to give you a bit of the political context, because in federal politics, even with very laudable goals, there's always an upside, or even some might say like underlying reasons for the choices that are made. So picture 2010, Stephen Harper went to Davos for their annual gathering. And when he was there speaking to the world's richest people, that is when Canada, which was chairing the G8 and the G20 meetings later that year, Stephen Harper announced that the country was going to focus on maternal, newborn, and child health. And the way he phrased it was, Canada was going to try and focus money on the poorest of the world's poor. And this was a little bit interesting because as someone who had followed aid for a few years at that point, the government had sort of started to move away from sub-Saharan Africa. They had focused the aid on other countries. They were increasingly aligning it with Canada's trade interests. And so to talk about focusing aid on the poorest of the world's poor and on maternal, newborn, and child health, that seemed to indicate that perhaps there would be another shifting back towards Africa. The theories about why exactly this was happening, right? We all know Stephen Harper's not known as a cuddly character. He's known as quite calculating and very smart about politics. And so one of the reasons could be that he needed to rectify his image as being, some would say anti-woman, others might just say neglectful of those issues, right? Missing and murdered Indigenous women was already an issue at that time. There were other women's issues, feminist issues that the Conservatives kind of didn't seem to be looking at that closely. So one of the reasons, the theories, is that he needed to kind of improve the Conservative government's image. One way to do it is, who can argue with helping women and children live longer? It also, the way they framed it, sort of sent a signal to the social conservatives who had gotten no love out of the Conservative government on abortion or on gay marriage. Focusing on women and children, it's literally motherhood and apple pie, and certainly warmed up the image a little bit that way. It fit the Conservatives' family-friendly image. And I think that theory actually is backed by the number of months that it took for the government to announce that, yes, contraception would be included in the funding. As soon as he announced the program, there were immediately questions about what this would cover. Would it cover abortion? Would it cover contraceptives? And it took a couple of months before the government confirmed no abortion with Canadian funding, yes, contraceptives. And we'll get to that a little bit more later, because even there's a bit more context. So when Stephen Harper stood up at Davos, he talked about the Millennium Development Goals. These are goals that, as you probably know, were set in 2000. There were a series of poverty reduction goals. And the world at that point, in 2010, 5 years away from the end of the MDGs, the Millennium Development Goals, they were furthest behind on MDGs 4 and 5. So Millennium Development Goal number 4, as you can see, reduced by 2/3 the under 5 mortality rate. And number 5, reduce by 3/4 the maternal mortality ratio, and achieve universal access to reproductive health, which, as you'll see, has not been done. So in 2010, eventually, when the G8 met in Muskoka, Canada pledged $2.85 billion. Later on, Stephen Harper announced he would co-chair an accountability commission with Jakaya Kikwete, who is the president of Tanzania. Tanzania and Canada have worked closely on monitoring where the funding goes, tracking and making sure that the money that some of the countries are delivering actually goes to the people who it's intended for. Later on, Canada pledged $3.5 billion from 2015 to 2020. So let's look at the numbers. I don't have these written down, but in 2010, sorry, getting lost on my slides already. Since 1990, the maternal mortality ratio has been cut nearly in half, but most of the reductions had occurred since 2000. And 71% of births were assisted by a skilled health personnel globally in 2014. That's an increase since 1990 from 59%, so from 59 to 71%. When we look at some of the disparity, the income disparity or geographic disparity, children in rural areas are about 1.7 times more likely to die before their 5th birthdays than children in urban areas. And children of mothers with secondary education or higher are almost 3 times more likely to survive than children of mothers with no education. So with the 5-year countdown back in 2010, Canada took over chairing the G20 and G8. The numbers that Stephen Harper had talked about in Davos, more than 500,000 women died in pregnancy every year, and nearly 9 million children died before their 5th birthdays. That, in 2013, had been improved, so the number of women dying in pregnancy, not quite half of what it had been, 289,000 women a year died in pregnancy or labor, and 6.3 million children died before their 5th birthday. So that's down about a third from what it had been in 2010. Okay, why cover it? Personal interest, first of all. Like I said, I've been covering aid for a couple of years, so just that reason alone made me want to follow up and see what was going on. And then there's the journalism reasons, why everyone else is interested too, or why the other journalists sort of, in my world, are interested. We spent a lot of money on it. $2.3 billion is not a lot in the grand scheme of the Canadian budget, but it's a significant chunk of money, and you want to know where it went. There are some really excellent foreign correspondents from Canada, but there's only a handful of them, and it's not possible for them to cover all of this stuff. So I had a real interest in following up and seeing where that went. CBC also had an interest. They supported me quite a bit through this process. And I was also curious on the personal side about, after all of this time we'd spent covering contraception and abortion and that question, because abortion became a huge political issue on Parliament Hill, what was it like on the ground? Did people on the ground actually care, or did they think that the money could be directed to better goals? Finally, just politically, the Harper legacy. This was a man who had come in not really wanting to deal with the UN, not really caring about multilateralism, and one of his foreign policy legacies, I think, through this program is actually that he did end up working multilaterally with the UN and with some of the NGOs. Fortunately for me, there is the Travers Fellowship. So I was able to apply for the funding, pitch my story ideas, and get the funding that allowed me to travel and not give up much of my salary over the time that I had to be on leave. The fellowship started in 2012 after Jim Travers died. He had been a foreign correspondent, and he staunchly believed in the need for Canadians to follow what's going on in the world around them. So this fellowship has been fantastic. There's been 4 or 5 of us who've done it so far. Everyone's had slightly different topics, and it's just a really great way to ensure that there is some foreign correspondence going on in the media when there's, like I said, just a handful of reporters around the world who do this. So the limitations for my project, I had to take a leave from work a few months before the election, which I didn't particularly want to do. My bosses didn't particularly want that to happen, but we worked it out. So we had a real time limitation because I only had a small window to be able to do this. I had initially wanted to go to Tanzania and Ethiopia. Ethiopia's got some fascinating programs going on, but because they actually had an election around the time I was planning to be there, I was advised that probably it would be hard to travel. Some of the projects might shut down. And so with about a month to go before I left, I scrambled around and decided that Haiti would be a really interesting place to go to, simply because we devote so much money to Haiti, and it's a completely different environment from Tanzania. In terms of the assessment, I think this is important to note. This is not a scientific endeavor. I was not doing a forensic audit of how the money was being spent. So this is the information that I gathered through my research, through talking to people on the ground, through reports that I read. You could consider it absolutely anecdotal because, like I said, I wasn't crunching the numbers myself. Fortunately, there's an NGO in Ottawa that does that, and we'll get to that later. too. Also, a limitation, I spent a lot of time with the NGOs who were fantastic, but as a journalist, you have to conceive that that is possibly going to give you a bias. So I tried to control for that by having outside research and making sure that I took that into consideration. And then finally, communication, which I had thought about the need to have a translator. Obviously, I don't speak Swahili, I don't speak Creole, so that was a must. But beyond that, and beyond the fact that it took 3 times as long for me to do an interview because of the translation back and forth, it was just hard to communicate concepts. Like, if I want to know how different somebody's life is, and she lives in remote Tanzania with a primary school education and no internet or TV access, how do I communicate what my life is like and the differences between that? There was one woman who I spoke to, and I was really trying to drill down and just ask about her life. And I knew that she and her husband were subsistence farmers, and sometimes they had to work labor because they would run out of food and they needed to feed their kids. And I said, well, but what is that like? Is that hard? Like, how does that make you feel? And she said, it just is. That's just life. And I thought that was really interesting when you consider some of the whining that we're all guilty of day to day. We thought it might be interesting to compare the Canadian indicators, because I am going to talk a little bit just to set the stage with Tanzania and Haiti. I dug up some of these indicators. Some of them aren't really measured, obviously, in Canada. Like, it was hard to find a skilled health worker number, just because there are so many skilled health workers, I suspect, in the system. In Tanzania and Haiti, when I talk about skilled health workers, that includes doctors, nurses, and midwives. In Canada, obviously, there are a whole whack of health workers you might come into contact with. But I broke it down into physicians and nurses because those numbers were pretty readily available. So you're looking at 127.2 skilled health workers per 10,000 Canadians. Those are Canadian Institute for Health Information numbers. The fertility rate, I think everyone is familiar with, it's about 1.7. Under 5 mortality, very low. Maternal mortality, the Canadian Institutes for Health Information says it's too low to measure. UNICEF adjusts the estimate to put it at 12. We actually had an interesting discussion earlier, Dr. Buddha and I, talking about how you measure that, what some of the problems might be with that. And in fact, Canada's maternal mortality is like twice what Australia's is, so how do you work that out? Anyway, always more questions out of information. So turning to Tanzania, I visited several regions there. I started in Singida and then went to Tabora. Those are remote, rural, agricultural-based regions. And then I went on to Mwanza, Tarime, which is in the very north, and they have some issues with child brides there. Then down to Zanzibar and to Dar es Salaam. So if you look at the indicators here, Canada, I said there are about 127 doctors and nurses per 10,000 Canadians. Tanzania has 4.7. 49% of births are attended by a skilled health worker. If you break that down by income, it's also there's quite a big disparity between the highest quintile of income and the lowest quintile. It's also different when you're looking at people in the city versus in remote areas. The maternal mortality, under 5, you can see there 49 deaths per 1,000 births. That's a bit lower than the MDG target, so they did a bit better. And then maternal mortality, 410 out of 100,000 live births. Their target was 230. I think every country had a hard time hitting their maternal mortality target under the Millennium Development Goals. And that's something that globally people are trying to figure out why. I think we can probably connect that to some of the access barriers that I'm going to talk about shortly. And the source for all of these numbers is Countdown to 2015, which is a great resource online. You're probably familiar with it. The Lancet is one of their partners. So in Tanzania, this is a clinic. It is a dispensary. So it's a very small, it had about 6 rooms, and they do vaccinations, and they talk to the mothers about breastfeeding, that kind of thing. The focus in Tanzania, a lot of the aid work was helping the system develop its record keeping, because as you know, if you can't track how many medications, for example, you gave out last month, how do you know how many to reorder in the next month? Also just tracking how many women have been in for antenatal visits, how many deliveries have been done, that kind of thing. They're also training workers on these systems. In some cases, they are providing software or even computers and other equipment. And the big focus, the huge focus, and the emphasis across Tanzania was on lowering the barriers to getting women to medical attendance. So they really want women to be delivering in hospitals, but they also want to make sure that they're getting to prenatal care before the deliveries. And that's done mainly through community health workers. And those can be people with a little bit of training. They might be volunteers. They might just get an honorarium. And they have a rotation of visits that they do with women to make sure that, that the women are learning how to breastfeed, that they're emphasizing the need to see a health worker when you're pregnant, and proper nutrition and that kind of thing. So a lot of the barriers would be similar in other countries as well. The distance to a hospital. Your hospital might be hours away by motorbike, or you might have to walk to get there. You can imagine what that would be like if you're in labor. Some women actually even end up riding in donkey carts over bumpy roads just because that's the only access. The cost is an issue if you have to pay for it, if your family is not interested in spending that money, or if you simply don't have the money. Other family reasons might be your mother, your mother-in-law. She didn't need a midwife. She just had, the woman down the street who delivers everyone else's babies. So that's something that it throws up barriers to some of the women. Also, abuse by health workers. You take health workers who are maybe less educated than you would like. They work 24/7. If you have one health attendant in a village, in a particularly remote area, they might never get a break, because even if they decide not to go into the dispensary that day, people know where they live and they'll knock on the door. And just frustration too. Some of it comes out of the frustration of not having the equipment that they need to deal with it. And then there's also facility problems. So why would you go to a facility that maybe the toilet doesn't work? You have to bring your own water. You might have to labor in a bed with another woman for several hours in a room with 8 other beds with 2 other women per bed. All of these things can throw up barriers. So this photo here is from Singida region. It's actually a maternity waiting room where women can go in a few days or a week before their due date. Some of these waiting homes have room for their children as well, so they can go and they're at least at the hospital when they finally go into labor. It's one of the ways that they're trying to work around this. And of course, as you know, if you've been in a developing country, people are incredibly resourceful and incredibly creative, and they're finding solutions like that. I just threw in some photos so you can get a sense of what the facilities look like. This is that same hospital in Singida. There's, on the left, that is one of their supply closets, obviously, and then there's a nurse logging something that she's about to give out. On the left, again, the same hospital. On the right, that is how they develop x-rays at that hospital in Zanzibar. Yeah. It's not really safe for all of the hospital workers. This is a dispensary in Tabora. This is the labor room, where that's the bed that you might be delivering on. And then you can see some of the equipment they have, because they don't have electricity. And this was one of the ways that, one of the things that really impressed me. It's obviously a wheelchair made out of probably whatever was available. And then you get into the city. This is Dar es Salaam, and this is the Medical Distribution Center. This is, it's a government agency, and they distribute the medicine across the country. Behind the workers there, those are refrigeration units for vaccines that Canada funded. So they have each vaccine in a separate refrigeration unit. They've got alarms if the temperature drops, and that's the kind of facility that is more likely to be in a city than in a rural and remote area, much like Canada, more developed in the cities. Oh, and this is a hospital in Dar where this is part of the vaccine storage chain. Okay, so what I found out of my several weeks in Tanzania, to me anyway, it looked like there's a need for longer term funding. This is not anything that you won't also hear from the NGOs. The funding was announced, the Muskoka Initiative was announced in June of 2010, and then there was a 15-month lag before the organizations were told that they would have funding. So that then you're looking at the end of 2012. Then the projects have at most 3 years to get underway. They have to find their health workers, they have to set up their offices, they have to buy vehicles, they have to do all of that stuff. They've got a couple of years to do their work, and then by mid-2015, they're wrapping up, they're selling their vehicles, they're letting go of their workers. All of those things that you might think when something shuts down. So that's not a lot of time when you're trying to change a culture and get people used to going to see health workers. The work, sometimes revealed the need for ongoing funding. 2 years, like I said, is not a lot of time. And some of the numbers even that they were collecting raised more questions. So one organization had found that demand for contraceptives had steadily increased for about 1.5 years, and then it started to drop. And they didn't know, though, if that was because everyone had been asking for semi-permanent or permanent contraceptives, or if they had just, for some reason, stopped being interested in getting them. It also makes it hard to plan for the NGOs when they don't have the long-term funding. Even if they had wanted to stay in these regions and had applied for funding, they didn't know if they were going to get it, because there's also a lag time between the first and second round of funding. On to Haiti. The first indicator there is a 1998 number, so it's basically useless, but I threw it in anyway. Haiti, they lost a lot of their health work, or a lot of their civil service in the quake in 2010, and it's a 17-year-old number anyway, so you would expect that it's probably changed. But 37% of births were attended by a skilled health worker as of 2012. Again, if you break it into income, it's a huge disparity. The percentage of births attended by a skilled health worker was under 10% in the poorest quintile in Haiti, and about 80% in the richest 10% of Haitians. Fertility rate is a lot lower than Tanzania. It's 3. Of course, that varies. In Tanzania, it wasn't uncommon to hear about families with 9 children. The under 5 mortality actually is worse than the Millennium Development Goal target. It's 69 versus the 49 they were aiming for. And the maternal mortality is about twice as high as they'd hoped it would be by 2015. In Haiti, there was more of an infrastructure focus. A lot revolves around the 2010 earthquake. It destroyed so much of Port-au-Prince and some of the surrounding areas. So a lot of the focus is on infrastructure. Canada built this beautiful hospital in Gonaive, which is north-ish from Port-au-Prince. And they're just gradually staffing it up now. This man here, he has learned how to build water filtration systems, and he has since become a trainer, so he trains other people how to do it. That's attached to a Canadian NGO that does work in Haiti. They train people up, and then those people become trainers so they can keep training other people, additional people on water filtration. Water and sanitation was a big thing there, even convincing some people in rural and remote areas that toilets are really important to their village health. And again, the lack of the civil service. This is a photo from a community health worker gathering in Terre-Neuve, which is sort of close to Gonaive. These workers go in, they vaccinate children, they weigh them. You can see the scale kind of in the middle hanging from the ceiling there. They get everyone in at once, and they just go through every family. They've got like index cards, basically, with all of the families, the children's information. That's the same meeting. You can see the tools of the trade, including a megaphone. Right. So contraceptives, as I said, that was a big question for the Canadian government. As you know, probably, it's a health issue for women. 225 million women around the world have no access to contraceptives but want them. But this also ties into wealth, because if you can't limit the number of children if you choose to, then you might not be able to afford to send them all to school, or you might not be able to send them anywhere past primary school because you've got more on the way coming up through the school system. And of course, it's also linked to health, where you need to be able to space your pregnancy so your body can fully recover so that your baby is healthier when your baby is born. Despite that, 1.3% of the Muskoka Initiative funding went to contraceptives. These numbers are gathered by the Canadian International Development Portal, which used to be run by the North-South Institute. It's since moved over to Carleton University. And the data comes directly from the Canadian government. The CIDP just kind of crunches it in a way that is readable for those of us who don't know how to scrape data from the government website. 4% of Canadian aid overall is going to contraceptives, so it's a little bit higher, but aid has also been declining since 2011. While maternal health funding has gone up a great deal, the overall aid budget has declined almost $1 billion. And as we know, too, unsafe abortions cause 13% of those 289,000 maternal deaths worldwide every year, and that number is from the World Health Organization. So I wanted to explore whether this was an issue on the ground, as opposed to with journalists pestering Bev Oda, who was the former minister of CETA. And what I found was it's kind of split, because there are a lot of gender equity issues in Tanzania and Haiti. And so at one level, the women might not even want contraceptives. Maybe their husbands don't want them to take birth control because their husbands think that they should have as many children as possible. That's one level. Distribution can be really difficult when you get to a remote area. Maybe they're just not available. But other people talked about how they would love to see more Canadian government funding. One of the NGO workers, the program coordinator in Singida, had heard me asking these questions to the nurses. One nurse told me they ran out of Depo-Provera all the time because the women preferred it, because they could take it in secret. It's an injection. Their husbands didn't know. They could space their pregnancy, and it was only their business. So this woman had heard me ask these questions. I interviewed her about sort of other things, didn't ask that question because she's on the ground, but she doesn't deal directly with the patients. I turned off my recorder, and she stopped, and she said, "Don't you want to ask me about birth control?" And I said, being a good journalist, I said, "Yes, I do. I think you have something to say about birth control." Turned my recorder back on. And I should preface this with, she's very Catholic. She told me that abortion is killing, abortion is wrong. She's completely opposed to abortion. But she said, the Canadian government needs to put more money to contraceptives. It's the only thing. If you don't do abortion, it's the only thing. She said it was vitally important. And so that left a real impression on me. So the overall finding, the money was delivered. And again, this comes actually through the Canadian International Development Portal through the North-South Institute. They actually delivered slightly more funding under the maternal, newborn, and child health programming. So we know that that went well. The programming was short. It's hard to change cultures when you have basically 3 years on the ground to implement your programs. But Canada actually did its job. The goal, which was to leverage more funding to tackle the Millennium Development Goals 4 and 5 on maternal and child health, Canada leveraged more money. I talked to people in New York, sort of the big NGO area and attached to the UN, and they might have had quibbles with the abortion angle or with the contraceptives angle, but they said, no, Canada put its money where its mouth was, and they got more money leveraged over the years, thanks to Stephen Harper. So looking ahead now, this is from the Liberal Party's platform. They have not said anything about ending the maternal, newborn, and child health program. They like it. So do the NDP, by the way. The NDP wanted to increase the aid budget. The Liberals have not promised to increase the aid budget, although they say that they will not lapse funding, which sometimes happens where you budget for it in the federal budget, and then you don't approve it at the ministerial level, and so the money just sits there, not spent. The Liberals say they're going to end that for the development agency. They do say they want to close the gaps in reproductive rights and health care, which means it means abortion, and it means increasing funding for birth control. That also, though, raises questions for the NGOs. I don't think any of the NGOs are going to be comfortable going out and doing abortions where they're illegal, and obviously the rules are different in every single country. The mandate letter, which is something the Prime Minister sends to the minister, focused on refocusing on the world's poor and most vulnerable. And the NGOs actually hope that means fragile states. Everybody's talking about South Sudan right now, and so we'll see where it goes. Minister Bibo is actually, she talked to some of the NGOs last week. They were in Ottawa to talk about Syrian Emergency Fund matching funds, and then they had meetings as well. And Minister Bibo is meeting this week with officials in the department. She's had all of her briefings, and they're at the point now where she's going to talk to them about where she wants the agency to go. The agency meaning the former CEDA/Global Affairs Canada, which is now wrapped in. We're still figuring out how to refer to it, I think. And then the Sustainable Development Goals. So the MDGs, the Millennium Development Goals, ended at the end of 2015. The world now has the SDGs, which were basically passed through the UN at the General Assembly last fall. They've got 17 new broader goals with 169 targets, including no poverty, no hunger, and gender equality. But there's so many to focus on that I think one question is maternal, newborn, and child health going to continue to be a focus for the UN? And then will Canada still play a major role? The Liberals seem to like this program, but it's not theirs. And you know, it's hard to judge because when the UN met in the fall, it was the middle of the election. And so Canada sent the deputy minister of the department and no politicians went. So it's hard to know how politically engaged it is. So as you can see, I think like researchers, journalists do all of this work and we end up with still more questions to answer, maybe with more rounds of international trips, I don't know. But those are my findings and I'm happy to take your questions.
So let me be very specific. So irrespective of the politics, one of the, I think, failings or perhaps missing things in the Muskoka 2 initiative, and one was lack of focus on reproductive health. And even if it was there, it was with a small r rather than a capital R. Do you think that the new government ought to specifically fill that gap now with whatever's remaining in Muskoka 2 over the next 5 years with an explicit undertaking to enhance funding for family planning, post-abortion care, and enhance the components of adolescent health within those grants?
Okay. So Stan, you had a, thank you. Let me start
Laura,
with two, just kind of low.
Thank you very much for your comments and observations. They were very interesting. One of the issues that our center has coped with, I think, reasonably well over the last 3 years, was the concept that the old way of doing things around development was not going to be continued. And when I talk about the old ways, at least from a hospital perspective, the old ways were described as a group of physicians and nurses renting a plane for a week, flying in somewhere, doing something that was necessary for the community, but leaving and really not leaving too much behind. One of my concerns about Muskoka 1 and even Muskoka 2 funding is the lack of a focus on sustainability. You mentioned that you thought the length of the program was potentially too short. In fact, probably only about 3 years out of the 5. My question is, did you get a sense that in the communities or the organizations or the governments where we are working, that there was any skin in the game from those local communities or governments? And do you think that, this may be difficult, but do you think that in the future there will be more of a focus on sustainability, maybe even longer programming periods? But I think that the issue of sustainability to me is phenomenally important.
Thank you, Stan. Let's start with the first two then. So the question around should we enhance our focus on reproductive health and sustainability? So.
Yeah. So my understanding is that the second phase, 2015 to 2020, some of the NGOs who are getting the funding, they're aware, but there have been no formal announcements made. There was a bit of a slowdown ahead of the election, and then during the election, they don't tend to make announcements like that. So it's probable that they aren't going to be able to shift right now unless the government commits more funding. Although, I'm not an NGO expert, so I don't know if maybe they can sort of refocus if the government were to ask them to, but I would think once the proposal's in, it's been accepted, the funding's out there, I don't know that they are able to shift that much. In terms of adolescent health, that's a really good question. I heard a lot about that being sort of another frontier. Sex education, right? If you are in a remote area with no access to the internet, or just sort of, the culture that kids in Canada tend to grow up where it's everywhere and you can learn about it pretty easily. But if you don't know how you get pregnant when you're 13, like, that might be a problem. So that's something that I think people are aware of and talking about. In terms of capacity building and sustainability, I didn't emphasize that. That was a big emphasis when I was on the ground. The NGOs are very aware, and they're focused on trying to figure out how to do that. When you're looking at the community health workers, though, when the funding ends, I don't know how you convince people to keep doing what could really be a full-time job. Like, how do you keep those workers? And in some instances, the region will pay them, but then you're depending on a government that might not actually be delivering the funding to the hospitals anyway. So are they going to be funding the community health workers? But absolutely, sustainability is something that they're all working on. I think the question is, how are you sustainable once the NGOs have had to pull out?
Thank you very much. Enjoyed the presentation. So much of the presentation sort of focused on maternal health and maternal mortality. I'm wondering if you could speak to some of the childhood mortality or childhood initiatives that perhaps the government put in place, if they did at all, and if there's room to grow there as well, and what you saw on the ground.
I wonder if you could comment on the committee on accountability that our former Prime Minister was on with the President of Tanzania.
I work on a project in Ghana, and in speaking with a few friends who grew up on native reserves in Canada, received some criticism from them of why you're working there, and this is in your own backyard, and there's, tough situations here as well. So I'm just wondering, from your series of articles, what kind of responses you had from Canadians, either maybe online comments or in person when you've met readers, and what sense you got of Canadians' opinions of the aid.
Okay. Yeah, I'll start with the last one, because that actually is a really interesting question to me. And to the point where I had thought about pitching like a trip to the north or to Northern Ontario to do a comparison of how the systems are similar or different. I'm not an expert by any means on like First Nations issues or reserves. I think there's funding differences because reserve healthcare is funded by the federal government as opposed to the rest of the health system, which is funded provincially. The Liberals have committed to increasing First Nations education funding, so K to grade 12. I don't know that they've made any promises in terms of healthcare. They are going into talks actually next week in Vancouver. They're meeting with all the provincial and territorial leaders, the premiers, basically. Sorry, no, the health ministers. All the provincial and territorial health ministers are meeting with the federal health minister, Jane Philpott, and they're going to be talking about renegotiating the health accord. The Liberals have promised to do that, but they haven't attached a number yet because they say that they want to hear from the provinces and territories before they do that. That's maybe a broader answer than you were hoping for. Okay, and then on the Accountability Committee, I actually have been meaning to look into whether Stephen Harper is still going to be on that committee, because he and President Kikwete were co-chairing it, but there are a lot of people involved in that work that are not leaders of countries. Everyone was talking about all the information gathering that they had to do, and I know that some of the reporting was helpful. I didn't focus so much on that in the end. I was sort of more interested in what I was seeing on the ground. But certainly, Tanzania did quite well on its indicators, and I am guessing that's partly tied to the fact there was such careful monitoring going on because it was their leaders' project.
So did Tanzania get any sort of extraordinary funding from Canada? Was there any favoritism or anything like that?
I can't remember how they rank in terms of the Muskoka Initiative funding, but they certainly were one of, I think, 10 countries we focused on. I had this all in my head when I wrote the proposal a year and a half ago, but I'm less. Yeah, okay, yeah. Yeah, so they were one of the 10 that we had sort of that we focused our funding on. In terms of child health, a lot of the causes of child death, like the under 5 deaths, actually come from things that are quite easy to fix, like vaccinations, mosquito bed nets, like oral rehydration salts, vitamin treatments, that kind of thing. And so I didn't focus so much on that. And also just because as an indicator, everyone did better on that than on maternal health. When you look at the bulk numbers, I mean, you could ask whether the gains on maternal health were less because there was less room to improve, right? When you're looking at 500,000 deaths to 289,000 versus under 5 deaths, 9 million to 6 million, you know, it's a bigger gulf to fix. But I was more interested in the end in the barriers to access because of what I saw and heard about in Tanzania.
Hi, thank you for your presentation. So I had a question. In a lot of the communications and in Stephen Harper's speeches and other minister speeches, women have, like, the framing of women was often poor women, marginalized women, or pregnant mothers, poor mothers. Women were never kind of spoken as not mothers. And I was wondering whether that kind of discourse around framing of women was translated into in-country experiences and what kind of impacts that might have had.
This thing on? There we go. Hey, Laura, I wanted to ask you about the pitch that you conceived of when you're sitting in Ottawa, presumably, and how that changed, whether it was a details or example, but what changed between when you thought of the idea and the pitch to actually writing the stories?
The pitch, it's funny that you asked that because I conceived of it as a very broad, easy to digest question of, is Canada's aid working? And then when I looked at it again before I left, I was like, what was I thinking? Why do I think that I'm going to be able to answer that question with a month of traveling and research? And I was telling that to the High Commissioner in Tanzania, and he said, oh yeah, if you can answer that question, please let me know what you find. So it was sort of, it seemed like a great idea to conceive of that. But then, you know, obviously, even before I left, I knew, well, I'm not going to be able to answer that question. Like, people devote their lives to this field, and they can't answer that question. So certainly seeing the complexities, too. And I guess, like, the contraceptives question points at that, right? Where sitting here, it's easy to think, well, we just pay for them, and then the women can have them, right? And on the ground, there's the family barriers, like, do the women want them? Can they talk about it with their husbands? What do their husbands think? Distribution. So in Tanzania, they have had huge issues with MSD, which is the agency that distributes the medicine. So, and then being availability. Like if MSD goes by once a month, then maybe they run out for the last 2 weeks of the month, right? Or even prescribing. They might not have doctors around to prescribe them. So I guess that's it speaks to the reason for why journalists need to travel. This is why we need foreign correspondence funding, because you can't understand it the same way unless you go. The responsibility of media. We're not responsible for advocacy. And that's not, I'm sure, a satisfactory answer because I know the power that we have. Like, I had the ability to focus an audience on these questions. And unfortunately, you're kind of subject to what interests reporters. And part of that might just be, well, the politics are really interesting. Like, we've got an election coming up, and it's been 5 years since this funding was announced. So how is it going to affect Stephen Harper? Basically, too, it comes down to money. The newsrooms don't have money anymore. So you should all be subscribing to a newspaper and a magazine because that would help a little bit.
Any recommendations?
There's a really great national news magazine. The funding's not there. And I know actually the NGOs are trying to work around that. They would love to send people to visit these projects to see what they're doing, and they offer it whenever they can, but because of our ethics rules, right? Like, because there is a risk that you just then write a favorable article about the programming, you're not allowed to. None of the newsrooms will let people do that stuff. So there is this desire to connect, and I can't think of a reporter I know who wouldn't jump at the chance to do the same thing that I did, but there's not the funding, and that's a major That's a major gap for people who are interested in this kind of stuff. And the first question, I love this question because I meant to touch on it in the presentation. And I mean, I kind of got into it at the start with the political context, right? Of like the social conservatives and the Conservative Party being family friendly. All of their messaging is like that. The Conservatives were really strong on consistent messaging, so to the point where everything was about the economy, and I went to a news conference once where the news release was talking about this new defense project, and it was like, defense to build a strong economy for Canadian families, right? Like funding some kind of weapons contracting or whatever. And I just thought it was funny they would also mention Canadian families in the same, like it was a weird message. So the messaging there obviously was families and mothers, and there is that concern that you're taking away the agency from women, where you're talking about them only in terms of their relationships with others. And it was all about Canada will protect and save mothers and children. It's not about giving people the means to do it themselves.
Please join me in thanking Laura for a really thoughtful and I think different than the sort of global leadership series speakers we have in general. You both gave this wonderful sort of context. You have a political attunement that's very helpful both in your opening and in your closing framing, which I think is very interesting to everyone here. And just then your experiences on the ground. And particularly thank you for your work in bringing these sorts of issues to the Canadian public in a thoughtful way and for sharing them with us today. So please join me in thanking Laura for a very thoughtful discussion.